All right, this was the presentation I gave to my colleagues at the hospital during my final externship. It's a quick overview of my capstone poster. First of all, I wanted to give a shout out to my professors and my wife for their support. A quick story though, I was inspired to take on this project when my college roommate Jared and I had an argument about whether the sound was the same as the sound. I wasn't familiar with psycholinguistics back then, but I knew that we both had different language backgrounds. Right, I learned both Tagalog and English from a young age, while he learned English as a child and then Spanish as an adult. I wasn't sure whether he could actually perceive the differences in versus or he just couldn't produce them. Okay. But again, this was before I began my um, doctorate program. So here we are. The first thing we need to know is that in healthcare, this is the background. The number one reason for negative health outcomes was miscommunication, according to the WHO in 2007. According to another study, 20% of the population was found to be overconfident at identifying clinicians based on their accents alone. So people with unfamiliar accents tend to experience more stereotyping, harassment, and job discrimination, right? So as controversial as it is, we know that accent modification is a service that is requested by both patients and clinicians alike. Second point for the background, Franklin and McDaniel propose a cycles approach because we know that the L2 learning process can be similar to the L1 acquisition process. So, in other words, suppressing so-called accented sounds follows the same pattern as suppressing phonological processes by children. So, these three studies, Day et al. In 1997, Gahari and Najad Golamali in 2019 and Al Saadi in 2021 demonstrate that it is effective to train adults in an L2 like we teach children their L1. So we know that dynamic assessments are an effective way for patients to learn while the clinicians can measure progress. It's just not as quick as some other models. And then finally, for the background, we do know from providing services that patients vary in their adherence and compliance, especially beyond the clinical setting. So these variations can be attributed to each person's bias and background and their zone of proximal development. Um, this thing called the trans-theoretical model of change. We'll talk about that in just a little bit, but pretty much the patient's willingness to push their learning depends on their current individual experience, right? Which stage of this trans-theoretical model they're in. Um, so we do know that patients are more likely to adhere to their regimen outside of our treatment plan when the exercises are convenient. So enter mobile apps. So the purpose of this project was just to investigate potential applications of dynamic assessment in mobile application assisted accent modification. So here are the models that we thought would optimize accent modification in healthcare settings. So first, the dynamic assessment model is a model in which the patient or the L2 learner engages in a pre-test followed by a training period followed by post-test. I was sold on this model when I was learning language development in my undergrad. My professor for language development class, Dr. Doug Peterson. I believe he's at the University of Wyoming. He was very good at selling dynamic assessment model. It is very effective for children. We know that it has the potential to be effective for adults as well. So the second bullet point, again, bringing this up, the trans-theoretical model of change refers to the stepwise changes that people go through as they change their health behaviors. So this is like the idea of the zone of proximal development, where there are phases in which people are more motivated to learn or change their behaviors. Okay. And then there are, this third bullet point, there are already mobile apps that focus on vocabulary and grammar in an L2. Think Duolingo, Rosetta Stone, Babbel. Okay, these are thought to be effective because they're so available. Your second language can literally be sitting in your pocket. And then finally, this last bullet point, the task recommender systems are machine learning algorithms that can meet our patients or our L2 learners wherever they're at in whichever phase they're in the trans-theoretical model of change. So this is what these concepts would look like. This on the left is the pretest, and I don't know if my pointer here will match up with whatever's on the screen, but this left side is the pretest, and then there's a training portion that would base the phonological lessons on pretest performance and also the trans-theoretical model, and then there would be a post-test. Okay. Depending on the normative change in scores and self-reported user goals, the app would then provide and post-test scores, right? The app would then provide recommendations of exercises or media that the users would consume for listening and practice. So at this point, I didn't know about Best's the author Best, their perceptual assimilation model in psycholinguistics, right? But I am just trying to present this slideshow the way that I did in my graduate program and for my capstone and also at the hospital. So bear with me here. There are so many limitations in this study. Okay, first, we don't have any data whether this is effective with L2 phonology learners or even dysarthria patients. But this technology does have the benefit or the potential to benefit these patients or accent modification clients, right? Especially now that AI is popularized, I do want to come back to this project and see if we can specify some studies. Second, while it is true that mobile apps like this could be used asynchronously, teaching speech sounds likely requires both a human teacher and reliable audiovisual equipment. Inherently, teaching phonology is a perceptual thing. Accents are a perceptual thing. And so it does require humans. For now, we'll see where AI heads. And then again, it does rely on audiovisual equipment, meaning if you don't have access to a quiet enough room, then tough luck using the app. But this again is the case for apps like Duolingo or Babbel. Um, and then third, we would need to know how this compares with non-mobile app assisted home exercise programs that are already existing. If this app doesn't perform just as good or better than these home exercise programs, then what is the point of developing this app in the first place? And then finally, one thing that would be beneficial is to use the data in this app to collect not only um, data to improve the app experience, but also to improve general communication. For example, as part of scholarly research for hypokinetic dysarthria and Parkinson's disease. And that's about all that I talked about in the poster, and then subsequently this presentation at the hospital. Here are the references, and you can pause as needed. Thank you so much.